Okay, everybody, welcome. We don't see a lot of people floating around the corridors, so let's just get going and make it the best of our time here. So, welcome. My name's Rob Johannes. Pronouns are he, him, and his. I am on the board of directors for the Canadian Alliance to End Homelessness, so thank you all on behalf of the board for being here today, especially for the last session of the day. I know it can be a little tiring. I don't know about you all, but I hit the snack table and there was those oat and date bars. I just fucking troughed those, get in my belly. So I'm like, woo! I am joining you from my home in the Council of the Three Fires territory, Chicago, Illinois. I previously was in Toronto, and before that in Vancouver. And some words I never thought would come out of my mouth, returning to Canada this time. I'm really excited to go to Tim Hortons. Whoa, yikes. That's the thing, is talking about that yesterday, the Tim's Double Double is not a coffee, it's the Tim's Double Double. It's its own beverage. Ugh, yuck. So we talk a lot about truth and reconciliation, and then sometimes you come in and there's land acknowledgements and all the pronunciations are royally botched and they're kind of glossed over. So I try to always make sure that it's done a little more consciously and a little more purposefully, especially in the nature of the session that we are doing here today. So I encourage you, wherever you're sitting, to plant both feet firmly on the ground, on the land that we are on. Close your eyes if you feel comfortable. If not, so I'd like to start our time together by acknowledging that Ottawa is built on the unceded and unsurrendered territory of the Algonquin and Anishinaabe Nation, who have been its guardians since time immemorial. Let us honor and celebrate the many First Nations, Métis, and Inuit people across Turtle Island as this land's traditional knowledge keepers and courageous leaders, past, present, and future, especially in the fight to end homelessness, which is our purpose for gathering here together for these few days. We are mindful of broken covenants, and we strive to make this right in all our relations. It's our chosen duty to make peace with the land and with each other. Here in Ontario, we are all treaty people. Many of us have come here as settlers, immigrants, and newcomers in this generation and generations past. I would also like to acknowledge those of us who came here forcibly, particularly as part of the transatlantic slave trade. Therefore, I honor and pay tribute to ancestors of African origin and descent. Furthermore, in recognition of the 10,000 and counting lives that continue to be uncovered at 139 residential schools across Canada, many of which have not yet been excavated, and the last of which closed in 1996, when probably most, if not all of us in this room were alive. This is not history. This is something we are living with, and in many cases benefiting from the consequences and exploits of these institutions. I ask now, before we proceed with our session, in honor of those lives lost, the responsibilities we all have moving forward towards truth and reconciliation, that we hold a moment of silence. Thanks so much, everybody. So you are in the session for providing holistic and culturally safe care. If you're expecting this to be a different session, stay anyways. It's going to be great. The panelists are just, I'm fueling off of their energy right now, not just the date bars. So in order to address social inequity in healthcare, support the wellness and needs of Indigenous peoples, trailblazing organizations across the country have developed Indigenous-Led, culturally sensitive and holistic programs. So here we're going to learn what they're doing in providing customized healthcare that honors traditional Indigenous practices and how you might be able to adopt these things into your community. As we go, I will allow the speakers to introduce themselves, because I find in this work, our stories and who we are is so intertwined with the work that we do. So it's a bit redundant if I introduce people, because we are the work that we do. And just a reminder for speakers to just eat the mic, pretend it's a date bar. Not just so everybody can hear you, but we're also simulcasting these sessions for people joining remotely, which is usually me, as you can tell, hence the mask. I'm going to tell a very short, just a couple minute story before we start with the first session. So almost 20 years ago now, I worked as coordinating a justice studies program at an Indigenous college in Vancouver, the longest running post-secondary institution in the country, actually. And in my first week there, I had a meeting with the Dean of Education, and he asked me, so do you work out? And I was like, that's an interesting question to get in my first meeting, but you know, new environment, I'm just gonna roll with it. I said, yeah, I do. And he said, so if you need to leave in the middle of the day, go to the gym, have your workout, have a shower, have a meal, come back, and if that takes you 2 hours, just go do it. Because we all have 4 parts of our medicine wheel, and your physical self is one of those. And if that part of you is out of balance, then all of you is out of balance. Whereas if you are in balance, your students will benefit, your colleagues will benefit, the whole college will benefit. And I said, really? That's fine. That's not an issue with like labor and such? And he said, no. Employees here aren't units of production. They are part of this organic entity that makes up this college. And if there's a problem with one cog in the wheel, we don't just hyper-focus on the wheel. We look at how the whole, we don't just look at the one piece. We look at how the whole wheel can actually better support that individual. I have never been in a work environment that was that healthy, that balanced, and that sort of organic. And I've taken that with me everywhere that I've gone since. The problem is I've always had to be the one to self-advocate for that wherever I've gone, because all of the other organizations, they can post a lot of statements about how we are anti-racist and this and that, but a lot of the policies are still very much based on a Western colonial model of employment. And given that 50% of our workforce in many organizations, we are the people we serve. We are the people with lived experience. We're coming from this background and using those as assets into the work. So hopefully this session will provide an opportunity to look at how we can decolonize ourselves, our institutions, in the work that we do. So we will have 3 sessions. The first one is on integrating Indigenous and Western healthcare. The second is on Indigenous street medicine, and the other is historic and culturally safe healthcare for the Indigenous community members experiencing homelessness in Montreal. So our first speakers are Carrie and Diane, and we'll invite you to come up and have at it.
I show it? Just go to from beginning? Oh, there we go. Okay, awesome. Well, thank you. Yes, my name is Carrie Cardinal. I'm the CEO for NiGiNan Housing Ventures. And I do want to take a minute just to recognize what happened at lunch today. There was a very traumatic event that happened, and I really felt for the people that, you know, had to take a minute to leave the room and really feel the pain. And I'm really grateful that we had the spiritual room and the elder there that was able to smudge us and sing a song for us. And I'm really proud of our people for doing that and taking that time to feel those feelings. That was hard to really feel. So I just want to mention that. I didn't mean to start out. Sorry. Anyways, so my name is Carrie Cardinal, like I said, and I'm just gonna quickly go through some information about NiGiNan Housing Ventures. We did have a presentation yesterday that lasted 90 minutes, so I'm not gonna make people who were in that presentation yesterday go through that again. So very quickly going to go through some information, and then Diane is going to talk about how we've been decolonizing housing and healthcare and how we've been incorporating our traditional ways into our healthcare system at NiGiNan. So at NiGiNan Housing Ventures, we're an Indigenous-led supportive housing agency. Okay, and we provide supportive, caring love to those that with really complex needs and those that are deemed hardest to house or hard to house. And and I'll just get out of your way. I feel bad. He's trying to do something here. Okay. And at NiGiNan Housing Ventures, the folks that come to stay with us, they've been deemed the hardest to house in Edmonton, and they can't be successfully housed anywhere else. People who come to us, they might have been on the street for decades. They come to us sometimes in encampments for years, and this is the first time, sometimes in some cases, that they're treated with kindness and they're treated with love, and they walk in through the door. You don't find in any of our sites, you'll never find bulletproof glass. You'll never find rules up on walls. We don't tell our residents what they can't do. We meet them where they're at. We provide them with that love and support and kindness. And then from there, we build our relationship and work on our Indigenous-led recovery model from there. And a big part of that is our healthcare system. So at the base of what we do, we follow the 4 natural laws. Our 4 natural laws are kindness, honesty, sharing, and strength. And everything that we do, we ask ourselves if we're following those. And if we're not, then we're not doing a good job, and we know we need to change. I'll just quickly go through some of our sites. There is at the end of this presentation a QR code to our annual report where a lot more information is in there. And I have, I think, 1 extra copy up there. But Ambrose Place is our first site. It was opened in November 2014. So this November, we'll be celebrating our 10-year anniversary of Ambrose Place, 10 years of success. We have 42 supportive units there, very high complex needs, a lot of physical and mental and addiction issues. And some of our folks that have been living there for years now, and we have 9 residents right now that have been living with us for almost 10 years. And that is after years and years of living on the street and having nowhere else to go. So our next site is Omamu-Wangogamick, and this site is our family site. This site was created in order to prevent Child and Family Services from being involved in the family. And a number of folks who moved in here in the beginning, their kids were in care, they were under PGO status, or they were at risk of being apprehended. In the past, according to the site supervisor, in the past 3 years since she started, there's been 20 kids returned to their parents from PGO status. So it's an incredible site. The way we do that, again, is we have created a community. And so in the building, there are 2-bedroom townhomes, and then there's also 1-bedroom suites and 2-bedroom suites. And we have cookums and mushums, aunties and uncles in youth that also reside there. And together, the expectation is that if you live there, you're there to support the kids and the family. Our third site is MacArthur Place. MacArthur Place is a Homer Trust-owned building, part of the Rapid House Initiative in Edmonton, and we have 50 suites in there. Again, very high needs, very complex medical, addiction, and mental health issues. And we have the same program there that is at Ambrose Place. I'm really running through this. If anybody was in the one yesterday, they know I spent a lot more time on that. I could talk forever about NiGiNan housing. So Pimatuwin is our newest site, and Pimatuwin is the old Sands Hotel, which has been renovated in order to accommodate 115 spaces right now. So in the tower, which this is a picture of, you'll see there's 54 units there, and then we also have 6 enhanced care suites, which Diane will talk about a little bit more in a minute. And then we have 55 Indigenous-led emergency shelter units, which are spaces where, rather than the traditional shelter where you kick people out in the morning, you can stay there for as long as needed, and you actually don't get kicked out. You stay there until you're housed. One thing NiGiNan has prided itself on is that we have refused to accommodate the request to do things in a traditional Western way, a colonial way. And for us, we would not run a shelter system until we were allowed to do it our way. And once we were allowed to do it our way, then we opened our doors and we started running that program. The people in the shelter, in our shelter, have the same access to all the programming that all our supportive sites do. They also get 3 meals a day, and we work with them on, getting their ID, getting their pay and stuff like that. So At the center of every of our sites too is a ceremony room, and the ceremony is where we start. So everything that we do is very intentional in ceremony. We have land-based training every Friday, and we also have a number of ceremonies ongoing all year. If you want to know more, you just follow us on Facebook. They're always posted. Yeah, like, sorry, yes, like and subscribe. So a little bit about how we have been decolonizing our programs. At NiGiNan Housing Venture, our 4 core program areas are housing, healthcare, food, and culture. And we have found with our residents, they come to us with a variety of different needs, and they can ebb and flow, and they can move around with these program areas. So we have to ensure that when we have different staff who work in different areas, that they're willing to accommodate that resident no matter what. That means that even if you're working for healthcare and they come and they need something that isn't a healthcare job, they actually have to do that. We call it Wichitwin. And one of my favorite things to say to staff are, you don't work for healthcare, you don't work for PDD, and you don't work for housing. You actually work for NiGiNan Housing Ventures, and we all work together in order to ensure that all the needs of the resident are met. And there's Diane.
Here I am. Please bear with me. I got notes because I forget stuff. Okay, so like Carrie says, we take an Indigenous, Diane. My name's Diane. I'm an Indigenous registered nurse for 34 years. And I think I said the rest. We don't want to take a lot of time me talking about me. So anyway, we take that Indigenous-led lead and foster a culture of holistic approach to our healthcare that very much beautifully was said with the medicine wheel earlier. We really take that. So supportive housing obviously takes a real crucial role in improving health outcomes for individuals, especially when we're looking at complex needs. So we have some on-site services, and we employ a robust team of LPNs and healthcare aides that are at our sites 24/7. So they really take some of our complex folks, and some of them have never seen a doctor or a hospital. There's not great experiences in hospitals anywhere. So we have to work on building those relationships, building that trust with a lot of our folks right from the beginning. Christine, if you were in her session yesterday, talked about a gentleman that wouldn't even allow anybody to see a wound on his leg, and they had to work sitting on the floor, talking a long time before he'd even have the trust to let you do that. So those are the kinds of folks that sometimes we work with. We also really try to employ some better management of some of the chronic conditions that they have. A lot of our folks don't even know that they have chronic conditions. And so we're, doing that through medication management, physicians, getting them linked up with some of those external supports as well. We do an Indigenous-led recovery model. In Alberta, we're not allowed to use the H word, harm reduction, anymore. So we had to come up with our own Indigenous-led recovery model. From the government. Yeah. So we do have in our sites, we have what we call a MAP program. And what MAP does, it employs an approach aimed at mitigating the adverse effect of alcohol and drug consumption. So a lot of our folks might come off the street, they might be drinking non-consumable alcohol like hand sanitizer or something, or just harder spirits. So it's a program they have to buy into. So we're not supplying them with alcohol. They have to buy into it. And then the team works with them to see if, they could start just wrapping some safety around some of that drinking. So it's usually done with beer, and they'll start at, say, 10 beer a day, and just work with them. And a lot of times, well, Marsan could probably talk to that. A lot of times it's just it sort of tapers off after time with some folks. Some maybe not, but we're meeting them where they're at. We do understand that some people will never give up the addiction issue, but that's okay. Like, we're just going to wrap some safety around it. We also have a managed cannabis program too, same kind of thing, maybe getting them off some of the harder street drugs and offering them cannabis. Again, they have to pay into it, so we're not supplying that for them. And so it's working well with a lot, I believe. We do not encourage use on our site, in our buildings. But we sometimes provide them safe areas, because we want to keep an eye on our folks. If they're using illicit drugs, we want to make sure that if they get into danger, that we can respond to them. And the staff is always doing safety checks and perimeter checks and keeping close tabs on our folks so they don't get into too much. And also our LPNs are the ones that manage the alcohol program and the cannabis, mostly because they have skills in assessment, so they can assess the resident if it's appropriate to give them their substance. What else? Palliative care. We're really noticing a lot of our folks are aging. So we're going to be moving into this palliative care kind of model, because they're going to stay with us. And so there's a thought out there that when our residents come to us because of their chronic use, their disease, and everything else, the hard life that they've had, that they're kind of palliative, when they do come to us in the beginning. And through our love and through our kindness and our help and them getting medication and getting, a warm bed and food, we're prolonging their lives. And we love that, but we are seeing that there is an aging population, and we'll probably look in the future, maybe in, get some kind of palliative suite. We have had residents, especially at Ambrose Place, who have passed, and they've had a strong desire to stay. They don't want to go to a hospital. They don't want to go to hospice, and we've made that happen for them. So it's very dignified, beautiful. The staff come together. We get a lot of help from external agencies as well, like Alberta Health Services has stepped up and helped, and an Indigenous wellness clinic has helped us because they have a palliative doctor. And so when a resident passes in our facility, we bring in our cultural team. They sing them home, which is an absolute beautiful ceremony. And we have people that come in and do pipe ceremonies or ceremonies after. They include the families. It's just a really beautiful experience, and we've given that person the dignity and the kindness that they deserve when we do that. I have now a clinical services coordinator. Now she's pretty important with me because we've got a lot of gaps in between. Well, we call her, it was a patient navigator fund that we got for her position. So we have a lot of residents that, for all those reasons I was saying, have gaps in the healthcare, don't seek out services. So her job is to really talk and bridge some of those gaps with some of our external forces. So we're funded by Alberta Health Services very heavily. We also have embedded staff that are Alberta Health Services. So we have OTs, we have PTs, we have rec therapists, we have social workers. So they really work a lot with us to help mitigate some of those other services that we need out there. And also just a conversation I had with, because she just got into this role I had with her. We also have gaps, like we have a lot of staff. Like over the last 2 years, we've tripled in size basically. And if anybody's in that field, they know staffing is an issue. We used to always say our residents are easy, our staff are hard, because it's true. And sometimes, sometimes what happens is our staff don't really take the time to read about our residents. So I'm going to incorporate her to help bridge that gap. So she can read the histories, and she can really find out about that resident, go to staff, and then like bridge that gap so they have a better understanding, because a lot of our folks are Indigenous, as you know, and there's a lot of history and a lot of trauma, intergenerational trauma, that people need to be aware of, right? And it's kind of what they talked about at lunchtime today, why it triggered me. But okay, did I get it all? Yep. Okay. Oh, and then am I doing this? Yep. Where is it? Okay, I don't know. I have to hurry though because you gave me the 5-minute thingamadooey. Okay, our enhanced care suites. So Alberta Healthcare just reiterated that there is an issue with our long-term folks that are sitting in hospital that are suffering houselessness. And there's not very many appropriate facilities to send them to because of their addictions or their mental health status. So we are piloting these 6 enhanced care beds. Now, these are all folks that have been long-term in hospital, and they've come to us and they have a trimorbidity of complex needs. So they have physical complexities, they have mental health complexities, and addictions. So they are really, really tough. Like, we thought we had the toughest house before. These ones really give us a challenge, but and we could fill these beds like 100 times over. Like, there's people phoning us all the time for these kinds of beds. But what they will, and it's a level 5. All of our other houses that have, our sites that have healthcare are usually like a level 3, 4. This is a level 5. So they are, some of the guys came with very complex wounds, amputations, all kinds of stuff, but we're really proud of them. This is, if anybody heard me yesterday talk about our gentleman that went in, this is the Taj Mahal I was talking about, the beautiful suite that I got to tell him he could come and live at. And he really touches my heart for sure. And then just to wrap up, I think we've got, a doctor's office. So we're hoping to plan for a doctor's office. It's really needed. We really need a physician. And not just to handle like the physical and the medication needs, but we run into problems with our residents that if they haven't been followed by a physician and say they need some kind of support like AISH, which is our Assured for Handicapped folks, there's a Part B that needs to be filled out. And a lot of times, if they haven't been followed by a doctor, doctors are very reluctant to do that. So then they can't get those supports. So we're really hoping, we had one in Locum this month, and it worked out really well. So we're hoping that we treated him really well. So we're hoping he comes back. Yeah. And then I think, and traditional medications, just to say, we are going to be consulting some elders, knowledge keepers, and really look into our traditional medications because we want to pair them with Western medication. Really, really important. But there's a bit of work to do, and we are hoping someday that maybe we can have a pharmacy. We visited Luma Health Center in Vancouver, and they did a beautiful job of that. So we want to do that too. Yeah. Is that it?
No.
Oh.
No, you still have like 5 slides.
Oh, it's still in 5 slides?
They're short.
Okay. So we just work with one pharmacy, and we do that for the safety of our residents. So there's no double doctoring, no double doses. It would be mayhem if we had all of our residents have all these pharmacies all over the place. So we just work with one, and we have really good relationships with them. And they provide a lot of teaching. They do our naloxone training, and they're just a really good partner. Oh, and what was I going to say about that? Food? Yep. So food, we serve our people 3 meals a day. So we know that, yes, they do have. Yes, they do. They have to subscribe to our food program. Their suites are equipped with kitchens, but we just know that you know, if we left it up to them, they'd probably feed their habit before they'd feed themselves. So we take that out of the equation. And the meals, like, that's one thing I really love when you walk into one of our buildings. That's the first thing you smell is like a beautiful meal cooked, and I think it just makes everybody smile, right? Yeah.
Yeah.
What's that? Bacon. That's right, Christine and her bacon. Okay, there. You do it.
Just a little bit of. Yeah. We have a QR code for our annual report if you want to take a picture of it and get our annual report. We're very proud of it. The cover art, we actually did a contest with our residents for the cover art, and that Carl is the one who got it. Sadly, he is now gone. They were very sad about that, but beautiful artwork. And yeah, follow us. And that's it.
So my least favorite part of moderating is having to vulture over people for time, because I feel like, you know, there's just so much wisdom being shared here. Like normally, I'm so anti-authority, so it's weird as well. Normally it's the asshole walking around with the clipboard, but now it's the iPad. So like I am that person right now. Very quickly before we move to the next session, thank you for that. That was so just so heart reassuring to know that's out there. I'm reminded of many years ago when I was working as a case manager in housing, and there was a young Indigenous gentleman there who was struggled a lot. I think more than a lot of the other residents on the floor. And we always had a hard time sitting down to meet and like figure out, okay, how are we going to work together for the next year, and what things do we want to, work on, and all this. And finally, one morning, I said, you know what? Okay, we're going to meet. So I went and knocked on the door, and I said, we have to meet right now. Let's do this. Now, if this didn't happen right in front of my eyes, I wouldn't have actually believed it. But he took a bottle of Smirnoff, this tall, cracked the seal, and in one go, finished the whole thing, put it down, and said, okay, let's talk. Now, I am also a person in recovery, 9 years, a couple of months ago. And, thank you. And believe me, I spilled more drugs than a lot of people do in their lives. But even for me to look at this happening, I thought, I need to check everything that I know that is true and real at the door, and I need to meet him where he's at, because if this is what he needs just to be able to sit down and focus, have a conversation, that's the place where we need to start. And we talk about the H word in harm reduction. And I was there in Vancouver when we were opening the first supervised consumption site, and I've had the same conversation for the last fucking 20 years, pardon my language, particularly heated right now because, what's going on in provinces like Alberta and now in Ontario with this heart hubs thing. And I'll always say the same thing. You can't go to treatment if you're dead. Thank you. Yeah. In many cases, the physical withdrawals alone will be enough to kill you. We're not ready to have the conversation about going to treatment yet. Maybe that's where we want to go eventually. But now we're just focused on getting through the next 24 hours, the next 2 hours, the next 1 hour. And that's the thing, is harm reduction is a spectrum, and abstinence is on that spectrum, along with everything else. And sometimes that's just what you need to be able to show up every day. Yeah. So, do you need to get at something here, Casey, for the next part? All right. Sorry for the rant there. Just you inspired a lot of thoughts. Okay. Indigenous street medicine, the concept of trauma-informed, Indigenous-led clinical medical, client-directed medical outreach. Suzanne and Melanie. Let's go. Excited. Okay, thank you.
Good afternoon, everybody. How's everybody doing? Yeah. So thank you. I wanted to say a thank you to Jeff for the land acknowledgement, and it's been a really great conference. We're coming from Alberta, so it's been great to be in Ottawa and meeting people and networking and able to present
how do I get it to start?
I know, I have the same.
I know.
There's like an icon. I don't know. So
Oh,
that
you
was-
click on your icon. Okay, got it.
Okay.
Simple stuff. It's all good.
And then you have to start.
Like that. Oh, I don't even need this. Here, you can hold it.
Okay, I'll help.
Yeah. Okay. Awesome. Thank you. I love it. They went first. So, just out of curiosity, how many people in the audience have been a part of a street medicine team before? Hey, awesome. You guys know. How many people know what street medicine is? Okay. Well, I'm happy to be able to share our experience today with street medicine that we had. Yeah, so medical outreach without walls. I always look to the East as being more advanced than the West when it comes to innovation and the advancement of medicine. So I myself have a master's of nurse practitioner, so master's in nursing. I'm a family nurse practitioner. But I also have been working on a master's for health administration and management. So I am a dual lens. And then Melanie here, she was with me in the street medicine team. So she's a registered nurse and has a wealth of knowledge. She's worked with the Blood Tribe for a long time. So we'll share our experience with you. So I always like quotes. Most of the important things in the world have been accomplished by people who have kept on trying when there seemed to be no hope at all. This is what we face every day when you are dealing with people and walking beside people that are unsheltered and suffering with addictions. Okay, so the Blood Tribe Department of Health, their mission is to have healthy people in healthy communities. So I'm not sure how many of you know about the Blood Tribe. A few things. They're the largest landmass reservation in Canada. They go all the way up quite a ways in the province of Alberta and then down into the States. The closest city to them is Lethbridge, where we are residing. Over 70% of our unsheltered in Lethbridge are Indigenous. And there was a recognition from the Blood Tribe that we need to get going with some Indigenous-led initiatives and culturally familiar care to the mostly Blackfoot population. Stop the stigma, work together. Thankfully, the city recognized this. We sat down at a table and decided to give a street medicine program a try. As you guys know, the opioid crisis has been on in Canada for some time now. And when we started researching out what to do with street medicine, we didn't just want to make up a program, but we went off the roots of the program that runs out of the Street Medicine Institute in Los Angeles. So they've been around for some time and they're well established. So we built our framework off of their framework, but we got to put an Indigenous lens on it. So that's where we started out with our program. Okay. Alberta Health Services, they are our provincial medical provider in Alberta. So we partnered with them because they already have programs up and running. Makes sense. Other partnerships that we had, we looked at where services were being provided. So we didn't want to just kind of charge in and take over. It'd be fun to do that. But we wanted to work with what was already in place and kind of augment and collaborate and work together. So that was where the aim of the program was. Some of the areas that really appreciated our program, and we didn't really think about that, were areas such as the Lethbridge Police Services and the EMS. Those two partnerships became really, I'm going to say supportive of us because we really reduced a lot of demand on their services, and that wasn't a primary objective, but it was a definite benefit for everybody. So the precedence of street medicine is helping without four walls. We know our unsheltered population, they don't have anywhere that they can go. And when you make an appointment for them, let's say Monday at 9 o'clock in the morning, they may not make it, most likely, right? A lot of the times when we approach people, the number one thing they would ask is, hey, what day is it? What is the date? right? So they struggled because they don't have phones, they don't have calendars, they don't have watches. So a lot of them really just needed to know the basics. So how can we expect that someone is going to show up for an appointment when they don't have the tools needed to know what's going on? So that was one of the things that was really interesting as a gap in care. So sometimes they just can't make it. Physical was a gap. So Lethbridge is a little bit spread out. We are considered rural, but it's still okay. A lot of people could not get to a medical clinic because they would have to walk. A lot of people couldn't remember the last time they had seen a doctor or a nurse practitioner. They were open to seeing somebody. They knew they needed help. They knew they wanted help. And the other areas that we started to look at were mental health. Mental health was an issue for a lot of the homeless people when we talked with them. They knew they wanted help, they didn't know how to get help. Or they were frustrated with the help that they had been offered because they didn't think it was very helpful. So it was interesting to gain that lens actually coming from the people and what they were thinking. The other thing we were addressing was the alcohol, drug, and tobacco use. So there has been a lot of substance use, even during the encounters. We would have people that before their dressing change would take a hit because they knew it was going to be painful. And so it was an interesting ethical situation we found ourselves in, because as healthcare workers, we don't want to be causing pain. However, we do want to get the dressing done, and we have some cool ways that we mitigated that, so we'll share them with you guys. The big thing that we went in with the understanding. As Indigenous people, we understand the health inequities that are on our reserves. I worked with health inequities for most of my nursing career, so I get it. We can identify what we need so that we can meet those gaps. So we had an Indigenous-led initiative. The shelter is Indigenous run. There are a few non-Indigenous people working with us. We don't discriminate. The majority of our workers are all Indigenous, over 90%. So it's really a unique situation. We are blessed as a tribe. It's a big tribe, so we have the options. We know by research that an Indigenous-led team are successful in helping Indigenous populations. So we're maximizing the potential with the strength that we can provide to our own people. So the street medicine program was comprised of 3 people. So it wasn't a big, expensive, fancy program. It was bare bones, basic. And that was on the recommendation from the Street Medicine Institute. Start small and then work out. So that's what we did. So there was myself, nurse practitioner, a registered nurse, and a healthcare aide. That was the medical components of the team. And then there was 2 peer support workers. So one of us from the medical would always be on, and then the 2 peer supports. And the peer supports were probably more valuable, I'm going to say, than the medical. There was so many times when we approached people that they wouldn't really talk with us because they didn't know us, but they knew the peer supports. And so the peer supports would talk with them, and you'd hear them say, hey, you know what, this nurse is good. She's not going to hurt you. We trust her. And that would be your in. People that have tried to access the medical system as it is and have been traumatized by it, they just don't trust. And we can go with the attitude, we're going to break down that barrier. I think it's not the best way. That's on our agenda. So I know you guys spoke about we have to go to that person where they are. And really you do. It drove me crazy as a medical person sometimes because you see what's happening to their bodies physiologically and you know the disease processes. However, they have to be the ones to be in charge. And I think that was probably a really hard thing for me. Once I learned to, I don't want to say let that go, but to actually respect that part of the journey, things went a lot better for everybody. So it's sometimes I think as medical professionals, we're really driven to fix, and let me fix you. So I think that was probably a really good lesson to learn, a little bit of patience and humility in being able to go to that person and say, hey, how can I help you? Or better yet, would you like me to help you, right? So yeah, it was really good. We worked with the city and other partnerships. I know there's been a lot of talk sometimes at this conference about the encampments. We have encampments in Lethbridge, being a more rural area. The city has taken a really strong stance on encampment takedown. So we do see people going out further from the city center we have coulees around us. Very, very dangerous for people that might be substance using and overdosing. So it's a political battle all the time with trying to get people to balance that. Thankfully, street medicine can get around, and the police work really close. They actually ride bikes, so they can get down into the coulees. So we're trying to balance it. So lots of benefits of street medicine. The number one thing that I really appreciate as a medical professional is you get to take the time with the person. In the ER, in medical clinics, you have your 15 minutes, you have your 20 minutes. Here, you could just go and hang out. And really, sometimes that's all people wanted was an ear that they could just talk to, and that was it. And you gave them their water, and off you went. Sometimes they had something on their mind, and as you built that trust, soon people were seeking us out. We thought it would take about 6 to 8 weeks, which is about average for a new program to get up and running. It took 4. So again, it was a really quick need. People were hungry for help. So the findings what we learned, the gaps in care, there were many. There was lots, and you guys have heard as you've gone to sessions about gaps in care and the needs. And it's, as a clinician in the shelter where I work, we have those same needs. So I don't know if that's a good thing or a bad thing to come here and realize that, okay, good, we're not alone. You know, it'd be nice to have the solutions too. So the access on the emergency system, that was one of the biggest things that the doctors noticed. It really went down. People weren't going to the ER anyhow until they were so sick they were forced to go. And we saw some horrific things on the streets. You know, the wound that you can smell a block away. The person's embarrassed. They don't want to show it to you. They're scared, right? The maggot-filled wounds from the residuals from winter frostbite. There's some gnarly stuff that you see. There's a lot of violence on the streets that happened to people, and a lot of times when there's self-inflicted injury, whether it be intentional or not. So if someone is using and they pass out or lose consciousness and a hot glass falls on their leg, you got to burn, that type of thing. So there was a overwhelming appreciation, though, once we got out there and people realized, oh, these guys are a little different. It was really uplifting. It gave us actually motivation, and it made everybody show up. We might have been really tired every day, but we never were sick. We showed up because the people really needed us. So it was very, very motivating. The first week we had our vehicle parked outside the homeless shelter got vandalized, and we thought, oh, great, this is going to be a bad. We got a long summer. Within a couple of weeks, they guarded our vehicle for us. Nobody vandalized us again. So word out there, there's unwritten rules on the street that people follow, and we were really welcomed into that. It was difficult. There was difficult times, such as giving naloxone kits to the drug dealers in addition to those using. We had to be Switzerland. We couldn't say anything. We learned, you know, if you remove one drug dealer, you either put a target on your team's back or they just replace that person. You're not changing necessarily anything from that level. So it was tough. There was things that we didn't really anticipate with that, but we really were able to do that. So the gaps in care that we found, you guys, a lot of people talked about it. There's no primary care providers. So people that are really needing help, but people don't also want help because they've had some bad experiences. So we found that the street medicine program was able to bridge that gap. If we could identify and start doing daily dressings, even though it's a really bad maggot-filled wounds where you're thinking, oh my goodness, this person needs to be on IV antibiotics. They were able to actually have a pretty good outcomes and start the healing process. So making sure that their nutritional needs were met, making sure that the little things such as electrolytes, we started handing out bottles of water with electrolytes in it because everybody's dehydrated and electrolyte depleted. The strain on the healthcare system went down. There was the appreciation, and we actually really realized for ourselves that the whole process has to be client-led. Can't be clinician-led, can't be client-centered care with shared decision-making. Let them lead. They know what they want. They've been around, and they can tell you. Okay. So consent. One of the things we went out with kind of, I think, naively when we first started was we had little consent forms. No, no, bad call. Yeah, verbal consent was all you needed, and yeah, nobody was signing any forms. So yeah, we learned. But again, it's about dignity. That's all people have sometimes. So people will fight for the very thing that they have left, and that's their dignity. So you can empower them and trust them. And some of the things that we had to modify, for instance, when you're thinking about a medical encounter, if you had someone who has a dressing, even just asking them, like, would you like me to help you? Give them that choice, right? Yes, no. Maybe today's not a good day. Maybe they have to go get a hit first. Maybe they have to go to the bank or something else is going on. So check in with them. Letting them have the scissors to cut off their own dressing, right? Letting them decide how they want their dressing soaked off. Asking them if they want some benzocaine spray on their wound so it doesn't hurt so much. Allowing them to get involved with their wound care. We know that as nurses because we teach people to do dressing changes, but really just empowering that person to make those choices. What kind of tape do you want? That was a really big one. People were always picky about their tape. So yeah, just really learning those little things that made a big difference. Water, like I said, really super vital for survival. So we always carry bottles of water with us. And lots of people are dehydrated on the streets. They're not remembering to drink. A big hit was the hydrolyte tabs, more than the electrolytes. So they're a lot easier to pack. And people just lined up for those things. We tried them. We didn't think too much of them, but we're not electrolyte depleted, right? So they were popular. And then tracking. So we did have to do some tracking for ethnicity and gender. In the 4 months that we did our pilot project, 34 people declined. We saw over 10,000 people. So we were busy, and it was so rewarding. I can't tell you how much rewarding it was. So the big takeaways: client-led care, Indigenous-led teams, getting support from the communities. We know this. We know that's a constant fight, and perseverance. Don't give up, ever, because somebody's life depends on it. And you may not make a difference today or tomorrow, but maybe you'd one day make a difference for somebody. Okay. Thank you. Yeah.
We will do questions with all of the panelists at the end, and we're doing pretty good on time, so I think we'll be able to have a great conversation here. One of the fun things I have about coming to Ottawa is I get to catch up with a lot of friends and people from over the years, and I was chatting with a friend last night who works in the federal government. I won't say which department, but the head of the department, I guess in looking at the Truth and Reconciliation directives, approached her and said, we need to indigenize the office. And she said, how do you propose we do that? I said, maybe we'll put up a few pictures and such. And she looks at the director and says, are you fucking for real? So one of the first steps was actually hiring and paying well an artist to come in and do a mural on the wall. But it's also about just tearing down the whole building and like rebuilding it from the ground up. But, one step at a time. So there is a disconnect, sometimes between institutions, the colonial institutions, and how they think things are supposed to go. Which is what's so reassuring about what's being presented here today, is there's really wonderful concrete examples of how this is being done and executed in such an inspiring way. So I'm going to turn you over to our friends from Montreal, Stephanie and Kim, and let's hear about the program that you're doing just east of here.
Okay, where's the button? We can never find a button.
I'll come help you because they help me. Where's the arrow? There it is. Okay, you just get out of this. And then you go to yours. I don't know which is yours.
Right here.
Great. You go slideshow from the beginning. And then to go forward, you just press the arrow with the mouse.
Okay, perfect. In charge of that.
Okay, all right,
Go ahead. You start it.
I've got it. Okay. So, good afternoon. I don't know if I'm close enough. Okay. And so, thank you for still being here this late in the afternoon. We're here to talk to you about the Indigenous Wellness Project, which is a pretty special partnership between two different organizations that are working together to support Indigenous community members in downtown Montreal. And so my name is Stéphanie Marsan. I am of French-Canadian descent on my mother's side, from the Saguenay-Lac-Saint-Jean area. And on my father's side, I am of Albanian, Croatian, and Italian descent. And my father arrived in Montreal during the Second World War as a refugee. So I'm head of the addiction medicine service at the Centre Hospitalier de l'Université de Montréal, which is a bit of a mouthful, so we like to call it just the SHIM. And it's a tertiary care hospital in downtown Montreal. And I've been working with Indigenous community organizations in Montreal, as well as communities throughout the province of Quebec, to facilitate access to addiction services.
Okay, so I guess this is good enough, I guess. There. So my name is Kim DeLille. I'm Mohawk from Ganawage. I work for a shelter in Montreal called Project Autochtone de Québec. We call it PAC for short. It's easier, especially if you don't speak French. It's a lot easier. So I work with the Indigenous homeless community in Montreal. That's the urban setting. And part of my job is to facilitate and give them access to traditional and Western medicine in a culturally safe way in the hospital. Next. So basically, this is the outline of what we're going to present today. I know we don't have much time, so we're going to be really brief. So we're going to talk about the PAC-SHIM partnership she briefly described, the objectives and the timeline, the team and its partners, because we have many partners, and collaboration with other organizations, our research outline, our results, and the vision for the future. Okay, so Project Autochtone de Québec, okay, it's an Indigenous organization that accompanies First Nation, Inuit, and Métis people facing housing insecurity in Tiohtià:ke. Tiohtià:ke is a Mohawk word from Montreal, using a culturally adapted approach based on empowerment and harm reduction. We're allowed to use harm reduction in Quebec. Yeah, we're allowed. But we're allowed. So in Ottawa, I'll say something different. Okay, so PAC offers shelters, housing options and services that promote well-being and healing, strengthen in the community. We work in partnerships to advocate for the health and housing rights of urban Indigenous people. We have many shelters. So we have Pack 1, which was a day shelter for, it's 20 years now, celebrated 20 years. Pack 1 was a day shelter, and just this year it started to open for 24/7. Okay, yes, that's awesome. And then we have Pack 2, which is, Pack 1 is a dry shelter, by the way. So Pack 2 is a wet shelter. So with the wet shelter, the community members, we have a tent outside, and they can use that to consume in a safe place, okay? They cannot use inside of the building. So it's an old hotel building, but in the future, we have a new building that will be ready in a couple of years. Okay, then we have transitional housing, and that's attached to our Pack 1 building, and that's good for 3 years. They go there, they get life skills programs. It's got to be somebody that's either going to school or, you know, working on themselves and everything. And then they have a caseworker that works with them, and each shelter has 24/7 intake workers, and they have security at night. Okay, then from there we go to Oguazere, which is a Mohawk word for family, and that's new. That started within, I can't remember the date now, but 2023. I have 2 coworkers that are sitting there that will correct me. So, yeah, so that is a commune living space, and that's for men and women. In that building, downstairs we have MAP, which was already explained, the Managed Alcohol Program. And that's, when it first opened, it was all men. Now we have 2 women residing there. So Stephanie here is one of the doctors that works with the whole, all the community members there, and her team with the addictions. Okay, then from there, we have a brand new building that opened in July. Now, I cannot say the name because I didn't write it down. It's an Inuit name, so I'm just going to say the Sober House, because the whole team at PAC, we just call it the Sober House. They're not going to be happy with me, but sorry. Anyways, that's brand new, and they have, at the moment, they have 7 community members living there. So there they can live there for 5 years, which is really good, you know. So, you know, it's something new. They're going to be working with different treatment centers. You know, they have the nurses that's going to be working with them. They have caseworkers, and they have intervention workers as well. Oh, it's me again. Okay. So in Montreal, we have over 46,000 Indigenous people that live in the city according to the 2021 census. 16% of the people experiencing homelessness are Indigenous. Even if they represent only 5% of Montreal's population, it's very visible when you walk downtown Montreal, you will see them. Okay, members of the Inuit community represent 55% of the Indigenous peoples that are homeless in Montreal. First Nations people in Quebec have a life expectancy that is 8 to 9 years lower than non-Indigenous people. Okay, access to healthcare difficulties. The biggest things, the discrimination, racism, mistrust, misunderstanding of the healthcare system, missed appointments, and then the ER visits. I'm going to talk a little bit there. So this is where my job was created. So as the community health coordinator, my job is to make sure that all the, I hate to say homelessness, but the unhoused community members or whoever is at risk of becoming homeless, unhoused, we make sure that with the partnership from SHUM, that we receive all their scheduled appointments. So with that being said, we have scheduled appointments, so we know when they have a follow-up. We work with 4 departments. So the ER, the psych and detox unit, and then internal medicine. So when I first started this job, it wasn't easy. It wasn't easy at all. It was like, I'm an Indigenous woman walking into a hospital, you know, and I wasn't accepted at first. So when I first started, they were kind of cold to me. It was very difficult. For the first year, it was a little bit rough, but I found the trick. I had my business card made with my face. My picture was on it, and I brought it to every department. Everybody in ER had it, every department. Every time we went to an appointment, we put that card there. They got to know who I was. They got to know this face. So a year later, I received my badge for the hospital. So now I have access to any place in the hospital.
And so the Shim Hospital is in downtown Montreal, very close to Old Montreal, and it's surrounded by many different shelters. So a lot of community members use the services of the hospital and come to the ER on a frequent basis. But most importantly, PAC has many of its facilities around the hospital, and so a lot of its community members were using the hospital, but were also falling through the cracks because they weren't staying for the full length of stay at the hospital. They were coming back for their appointments, and so we realized that we really had to do something. And having worked on the managed alcohol program together in the early, at the start of COVID, we felt like this was a really nice progression, a nice way to continue to see the next step of what we could do together. And so the wellness project came to be. And so we were able to get some funding, and the aim of the project was really to provide holistic and culturally safe services within a hospital environment. But really, it meant much more than that. So yes, we have a liaison service, so that as soon as a PAC community member comes to the hospital or a person self-identifies as Indigenous, a person from the hospital comes and meets them, greets them, and gets to know what they would like. Is it about, do they want some translation services? Would they like to have visits from an elder? Would they like a healer to come and visit them? Do they want country food? And so we try to assess their needs. But the second part, and that's what Kim was talking about, is the whole idea of enhancing that continuity of care, the care trajectory, because between the hospital and the community, we're so used to working in silos in our own little sandboxes, and so we weren't getting all the information to the support workers that were working in the community, and so our aim was really to change that, and finally there was also, we wanted to change the hospital culture. So a lot of training, raising awareness that continues to go on, which is also very important. So we started in 2021, and at the beginning it was really about thinking, well, how are we going to do this? Thinking about the research questions. We're getting funding, it's a clinical project, and it's a pilot project. So in order for it to continue, of course, we need to evaluate it. We're now in phase 2, so 2023 to 26. We're implementing the project. Phase 3 is about expanding it to the entire hospital. So we started very small, just with addiction medicine, addiction psychiatry. Of course, we wanted to provide those services where most community members were at, so the ER and internal medicine. But we really want to make sure that once we've got things going, that things are really running smoothly, that we can really bring it to the entire hospital. And the phase 4 is we're already starting to work with the Ministry of Health to make sure that this continues and becomes part of every hospital.
So here's our whole team. So we have the PAC team. We have our program manager sitting way in the back. She can wave to everybody. Christina. There's myself, and there's my navigator, Tandy. Tandy is our weekend health navigator, and with that, she works Thursday to Friday. I had a Monday to Friday navigator for health, but we're just in the process of rehiring someone new. So that's in the works. And in the future, I'm looking at having an evening navigator for the transition because it's really needed. Then we have the SHUM team. And then we have, with the SHUM team, they have a research team. So there's Stephanie Marsan here, and Ramona is the one she was talking about on the bottom, who is the liaison worker at the hospital that greets the community members when they come in. Okay, our Indigenous Advisory Committee is really important to our project. They all have different backgrounds. They're all from different communities. And they're the ones that guide us. So whenever we need any kind of forms done, like our consent form took us 2 years for it to be official, a lot of fighting there, but we go to them. So we meet with them 3 times a year. Okay. That's yours.
And so when we started the project, there were only 2 of us. It was me and Kim trying to get this to get this working. And with time, well, we now have a much larger team. And what's been really important about working and increasing this circle of care is welcoming the community organizations into the hospital establishment. And so we have Kim's team that they all have their badges for the hospital badges so they can go everywhere. But we also have an intervention worker from a NADAP treatment center that also comes 3 days a week to visit patients. And we have a liaison nurse that also from another organization, from an Indigenous-led clinic that comes and does the liaison with patients and does the liaison with the community clinic as well. So really to help that continuity of care. And of course, people who are using the services are in Montreal, but they all come from different communities. And so they'll go back to their communities. They may go to Toronto, they may go to Halifax, they may come back to Montreal, so they're moving a lot. And so we felt like it was very important that we make connections and care trajectories with the communities throughout the province and with the different organizations. And so slowly we're building those care trajectories, and it's making a huge difference in making sure that we all work together. And we have a special trajectory as well with a nurse-led proximity clinic at the Native Friendship Center, which is where also the nurse liaison is working with. So, and that's made a huge difference. Just very quickly, of course, we do have to evaluate the project if we want it to survive and to continue. And so we're looking at different research questions. So we're looking at the different needs and priorities of community members so that we're making sure that we're offering the right services. We're examining the factors that influence the PAC-SHUM trajectory and partnership, and of course, assessing the effect of the healthcare on the health and wellness. And to do that, we're meeting with health professionals, we're meeting with community workers, with Indigenous community members through sharing circles, focus groups, one-on-one interviews, also chart reviews, just to make sure that we get everybody's insight.
Okay. So since the beginning of this project, well, I'm just going to go back a little bit. When this project first started in 2021, okay, I had a caseload of 5 people. Within the year, I went up to 180. To present now, present day today, I have almost 300, so 268 or something like that cases here. So this is how many appointments that we had went to, the team has did a compliments with. So then how many psychosocial supports, aftercare follow-ups is the most important. because without that, they're going to be left again behind somewhere. And then we have the outreach activities, and then we have medicine bundles we didn't really touch on. So each time we go to the hospital, we bring them a medicine bundle, and a care package. So with the care package, if they need any kind of undergarments, socks, puzzles, games, coloring books, whatever they want, we bring it to them. So, sorry, we do have elders that come to visit them. We have the translators, like she said. We have on-site 2 of them. There's Thelma and Mike that come around, and they'll come in, twice a week now. Yeah, so we'll switch. Okay. These are some of the requests that the community members have asked, either at the hospital or they'll ask me for. A lot of the things is they're asking for country food is the biggest one. Okay, they want their country food. They're asking to have circles, elders, translators, TVs in the hospital they would like to have, We do have a person that comes in and does cultural activities once a week with them. So we're trying to incorporate that. Clothing, and then just having the support of the navigators to go visit them when they're in the hospital to, and take them to all their appointments, follow-ups, and so on.
Okay, so we don't have any final results, but what we have noticed is really a reduction in ER visits. People are staying for the full length of stay when they are hospitalized, and they're coming back for their appointments. So that is huge.
Can you just give us 2 minutes? Thank you.
So just one last thing, because this is something that we're extremely proud of, because we want to expand the circle of care and work with the community, with the different community organizations and include everybody. We really felt that it was important that we work on that communication while respecting confidentiality laws. And so we met with ethicists, with community workers, with community members. We worked with the lawyers to develop a consent form where we get their personal information, their community support circle, their community circle of care, who are all the people within the community that are part of their care, as well as their wellness plan, what they want to have while they're in the hospital. And all this is with oral consent. So
it's got written consent and oral consent. They have to sign just one time. And after that, the lawyer said that we can just take oral. These are all the organizations that we have we work together with, we collaborate, we have navigators from each one of these organizations, and they help us out and we help them. Our final goal for this project is the circle of care. That's down the road, but we'll eventually get there. Thank you. That's it. We gotta stop.
So thank you.
Okay.
Again, I always feel so bad about the timekeeping and such, but the thing about conferences is these sessions are usually just the appetizer. The meaningful stuff happens out in the corridors with the one-to-one conversations while you're stuffing your faces with date bars and such. But we do have about 10 minutes or so we can take probably 2, maybe 3 questions. The panelists, if you want to sit up front, use mics. If not, you can just sit where you are. So if you have a question, just make sure you speak loudly so we can hear you. I might repeat your question into the mic just for everybody as well as the folks at home. Anyone have any thoughts? Yes, at the back there.
Thank you. To all the presenters. They were all excellent. But for the first presentation, who owns the housing models that were shown? There was at least 3 that were shared. Could you just tell me about that, please?
Absolutely. So with NiGiNan Housing Ventures, the first home that we own is Ambrose Place. We do have a co-ownership with Right at Home where we own 66% of the building and they own a third. The reason for that is because the community actually took us to court and we were stuck in court for 2 years mid-construction because the community didn't want that building in their community. That was in 2014. Thankfully, the City of Edmonton has done a lot of work around their bylaws and allowing community members to sue has really gone down. So the second home is Omamu-Wangokamic. That is another partnership with Right at Home. And so we own 50% and they own 50% of the building. And the third building is MacArthur Place, which is owned by Homer Trust. And Homer Trust owns it and we are the operators of it. And the fourth building is Pimatuan, which is completely owned by NiGiNan. This first home that we completely owned, first site. It was a hotel that was granted to us through the City of Edmonton and through a number of capital grants. We were able to renovate. It was about a $12 million renovation project. We still have part of the building, about a third of the building needs to be renovated. We have a couple capital grant requests out right now for that. And we just got 2 more grants from NiCi funding. We got $10 million for, they're called the Pimatuan plexes, which will be 14 plexes, and they'll be totally owned by us. And then we just got another capital grant of $10 million for Ambrose Place 2. So it's about a third of what we'll need to build Ambrose Place 2. And right now we're just in the process of finding the land and the builder for that. So we'll completely own that too. So, yeah.
Anyone else have any questions? Thoughts? I know that was a lot of material to take in, so feel free to think about it.
I was just wondering, with your street medicine, do you actually give medicine to, like drugs and stuff?
Yeah, so with the street medicine, because I am a nurse practitioner, absolutely. So we actually had pacts with pharmacies, so people in Alberta choose what pharmacy they want to go to when they're not admitted to a program. So we could just call in right off the street. We had a cell phone. So if somebody needs something, we can do point of care testing and then assessment and go. People also have the option to call the virtual ODP clinic, so opioid dependency, and start on Sublocade or Suboxone right on the spot. Again, really trying to break down those barriers for access to care for people. So thank you. Yeah, good question.
Any other questions? Any thoughts? I know it's late in the day, so we don't have to stay till 5. Not keeping you. Okay, cool. One of the things it says in the moderator guide is to provide closing remarks. Yikes. We're talking about health, that we also need to take care of ourselves. As of yesterday, you can get your COVID boosters and your flu shots in Ontario. I still have access to OHIP, so I snuck mine in yesterday, and it was great. Other than that, thank you to all of our wonderful presenters and panelists. Great job. Oh. And prenez soin de vous et des autres. Take care of yourselves and others, human and animal and nature, and have a good rest of the conference. Say hi out there.